Today we're going to go through chapter 13, which is the adrenal glands. So the adrenal glands, they're retroperitoneal, the same as the kidneys. They're generally located anterior, medial, and superior to the kidneys. So there's one on each side. Um, the main portions of them are the cortex and the medulla, and they have fatty connective tissue around to protect them. Glands are attached to the anterior medial aspect within the renal fascia, which is the garrota fascia. So they're adjacent to the kidneys superior. And here they are. They're anterior medial. So they're like right on top of the kidneys, basically. The right adrenal location is posterior and lateral to the IVC. So again, it's retroperitoneal, so that makes sense. And it's lateral to the IVC. It's medial to the right liver lobe, and it's lateral to the crest of the diaphragm. And it's triangular shaped. The left adrenal gland is more like an elongated crescent, and it's still on the medial aspect of the left kidney superior pole. So it's superior to the kidney. One thing to know is that the left gland is larger than the right. The splenic artery and the vein course between the pancreas and the left adrenal gland. Here's a little bit about the anatomy of how it is. Now you are not going to be quizzed on this, but it's nice to see that they're like how they are. Like it looks like the right adrenal gland is more like a pyramid shape, while the left adrenal gland is more like a crescent shaped. Adrenal glands are among the most vascular organs, similar to other endocrine glands like the pancreas. And there's an abundance of arterial supply. There's 3 arteries that supply each gland: the superior and medial, and the inferior. But what I want you to know is that it is just a very vascular organ. Each gland has a central vein which courses through each gland and exits the hilum. The right suprarenal vein empties directly into the posterior aspect of the IVC, and this left suprarenal vein drains directly inferior and medial to the left renal vein. So it kind of like makes sense, the right suprarenal, so superior to the kidney. Here's an image of that. So you can see how many little arteries are coming into the adrenal gland. And then, there's one like a vein draining out. So the adrenal glands, they're like, I'm sure you guys have heard a lot about as we've gotten to know more about what stress can do to the body and your cortisol levels. The adrenal glands control so much of that, and such an important organ for being so small. It just like does a huge part into our bodies, and it controls a lot of our hormone function. And some adrenal pathology or some medications have potential to disrupt level of adrenal hormones. So like if a patient has a tumor on the adrenal glands, their hormones are going to be all screwed up, of course, like their cortisol levels. But most of the hormones of the adrenal cortex are essential to life and must be replaced if the adrenal glands removed. So it's not like the gallbladder where you can take it out and probably be fine. Like we have got to have these hormones that the adrenal glands produce. So the cortex makes up about 90% of the adrenal gland. And that's what I really want you to know, that the cortex is a huge part of it. There's specialized zones. So zona glomer great. Glomerulosa is the outer layer and it produces aldosterone. Zona fasciculata is the middle layer and it produces glucocorticoids. And the reticularis is the inner layer and it produces estrogens and androgens. So there's like three different zones within this cortex that are producing different hormones, which is just insane to me. So the hormone secretion is kind of like an ovary where we're talking about like a negative feedback mechanism. So the hypothalamus secretes primary regulating factor. The corticotropin releasing hormone triggers the anterior pituitary gland and releases this hormone called adrenocorticotropic hormone or ACTH. So the blood concentrations of the ACH or TCH increase and adrenal hormone activity increases, producing a higher concentration of hormones in the bloodstream. Increased concentration of these adrenal hormone inhibits CRH and ACTH and ultimately hormone synthesis. So when the blood concentration of one or more adrenal hormones drops to low levels, the cycle is repeated. So it's kind of like what the ovary is going through with the estrogen progesterone. So the brain and the adrenal gland are talking to each other through this negative feedback system. So the medulla is not as big, but it synthesizes two principal hormones that you know, adrenaline or epinephrine or non-adrenaline or norepinephrine. And epinephrine is about 80% of total secretion. It's actually more important than the norepinephrine. Obviously, we know the fight and flight. We know all about adrenaline, and the adrenal glands are what produce that. The release of epinephrine and norepinephrine is usually stimulated through the sympathetic nervous system, and prompt discharge of this hormone usually occurs without influencing the cortical secretion. So what happens? Why would we get, epinephrine? Is probably anticipation, presence of stress, or pain. It causes the hypothalamus to signal sympathetic preganglionic neurons and to stimulate chromaffin cells and to increase output of epinephrine or norepinephrine. And this happens all within like seconds. So, like I said, like this is our fight or flight response. What also can happen is hypoglycemia, hypotension, hypoxia, and hypovolemia, and exposure to temperature extremes may also stimulate secretion of epinephrine, norepinephrine. Unlike the cortical hormones, medullary hormones are not essential to life. So I guess that's good, but it's really nice sometimes to have that adrenaline rush, right? When you need it. There's a couple lab tests that can be done to see how the adrenal glands are functioning. Here is an ACTH or corticotropin test. And if it's increased, it could mean these things. If it's decreased, it can mean these things. So maybe just be aware of that. Aldosterone, testing that steroid if it's increased or decreased. Cortisol levels, if it's increased or decreased, what could be causing that? Ketogenic steroids, increased or decreased, what could be causing that? Just be aware of those things. Usually there's no prep instructions for adrenal glands. And to be honest, I'd be very surprised if you ever just got a ultrasound for adrenal glands. I'm gonna be honest. Usually what we're gonna be doing is like the kidneys and we have a incidental finding of something in the adrenal glands. Again, ultrasound is not like the gold standard for adrenal glands. CT is more gonna they're going to have better imaging with that. So I don't think that you would just do a scan for adrenal glands unless there's some reason why they can't have a CT. So common protocols begin with transverse scanning followed by long. And the imaging goal is to document unilateral versus bilateral pathology. Now that once you know today what your adrenal glands look like, you should try to give it a shot on one of your classmates to see if you can find them. They're pretty difficult to find if there's nothing wrong. Sometimes you have to have the patient breathe in, take a breath, kind of just get away from the diaphragm and the ribs. You want to definitely use the highest frequency that you can and select a transducer with a small footprint. So you can go through the intercostal spaces. At the school, you're not going to be able to do that, so you're going to have to use a curvilinear probe. Liver and sometimes right kidney are useful in acoustic windows, and using the liver as the acoustic window depends on the hepatic size or attenuation characteristics. Transverse scans, use of intercostal approach and fine section of the IVC located medial and anterior to the upper pole of the kidney. And so you kind of look in between those two places. And then you should be able to visualize it. Yeah, it's just a lot more difficult than you would think because they're very small. This is showing a patient in a supine position, and you're taking transverse through like the intercostal spaces to try to find that adrenal gland, which is located like right here, if you can see in transverse. Sectional transverse illustrations demonstrates the relationship of adrenal glands to anatomic features, structures. So as we're scanning, this is what you're going to see, the adrenal gland and the crest of the diaphragm. Then you're going to go just over towards the right, and you're going to see the IVC, the pancreas, the liver, kidney there. And so just kind of scanning. So it takes a couple of tweaks to be able to see it. But a lot of people have the best success when they're using the liver as their window and the patient is left lateral decubitus position. So that would be my recommendation, because I feel like you can see a lot more stuff when the patient is in that on their left side. So using the liver and then looking that way, you should be able to see it. But yeah, it's pretty small. The left adrenal is even more difficult to document, and there's a couple of reasons. You have like the stomach and all that bowel gas right there. It makes it really difficult. But again, I think turning the patient onto the right side, maybe not all the way, but like an oblique is going to be the best way, and looking through the ribs. So the left adrenal gland, the longer coronal scan may be easier to obtain with patient in a right anterior oblique position, using a like left posterior oblique scanning plane. So this patient is like on their right lateral, and then you can see it kind of, they're scanning through on the side. So they're going through the spleen and the kidney, and you can see the little small adrenal gland there. So pitfalls, the size, location, pathology of adrenal glands is a limitation for sonographic visualization. Again, like cirrhosis, obesity, those are all going to be difficult. If a patient has really narrow or broad chest and the ribs are hard, that's going to make it difficult. Again, bowel gas and food is going to make it difficult. It's just going to be difficult. So I almost think like seeing the fetal adrenal glands, like when the baby is in utero, sometimes it's easier than to see them in an adult. And I don't know exactly why, and I haven't figured it out. Maybe food, maybe just scan planes, maybe, just better acoustic window. I don't know for sure, but I you got to be careful. And what we'll learn about as we're going through fetal ultrasound too is like sometimes the adrenal glands can look like kidneys. And so if a patient or a baby is missing a kidney, the adrenal gland can kind of appear, if you're not careful, can kind of look like the kidney in the fetus. So you just want to be careful with that. But a lot of the times you will be able to visualize both adrenal glands in a baby. In adults, they can be vary in shape and configuration, but let's know our length, width, and thickness. Um, and they weigh like 4 to 14 grams, so they're kind of little. You can't really distinguish between the cortex and the medulla, but the normal internal texture appears between homogeneous and hypoechoic. So transverse section, there, the right kidney is going to be more triangular. And I want to show you a picture of it. Okay, so here is one of the adrenal glands next to the IVC with the arrow in picture A. And B, you can see it in like a transverse section. It's going to be more to the medial of the right kidney and superior. And long, you're going to see it superior to the right kidney here. The left adrenal gland is going to be visualized superior and medial to the kidney. It's so difficult to see, guys. It's like ovaries, right? On transabdominal scan. So you just do the best you can, but sometimes you're like, oh man, this is ultrasound is just not very diagnostic for this. We can talk a little bit about pathology. Again, CT is the imaging modality of choice. I don't know how many times I'm going to say that. But it's another thing that we really got to know. So indications why we would do a sonogram, evaluation, presence of local or regional metastasis, localized tumor invasion, origin of retroperitoneal masses, characterization of adrenal hemorrhage, cyst, or tumor for cystic and solid components, patency of the local veins in IVC, hypertrophy of the gland, and follow up on a non-resected adrenal mass. Since a mass may be encountered incidentally, which is probably the most common thing, it's important to understand adrenal pathology. So that's why we do that. And to be able to know that there are certain lab values that are associated with the adrenal gland. And just to know what's normal now, normal. Now, I know that those pictures of the adrenal gland that we looked at on ultrasound are difficult to identify. It just looks like gray mass. But we need to realize that that's what normal looks like. And so if something is just a little abnormal or it looks a little funny, we're able to call that out when we're doing an ultrasound, and then they can follow up with a CT from there. With right adrenal disease, anterior displacement may include retroperitoneal fat line, IVC, and right renal vein. Inferior and posterior displacement may include the right kidney. And a large left adrenal gland, there's anterior displacement, or a posterior and inferior displacement may include the left kidney. On rare occasions, the adrenal tumor may invade the adjacent kidney. Here is a metastatic mass from bone cancer. I guess you could say if you can really see the adrenal gland good, there's probably something wrong with it. So this is the right kidney in image B, and you can see this hypoechoic mass next to it. And C, you can see a superior mass adjacent to the right kidney there. So if you can see that really good, it's not normal because you really shouldn't be able to see them good. Here is a sonogram demonstrating bilateral predominant hypoquick solid masses, which are the arrows. This is from a lung carcinoma. Here's another nasty looking mass. Almost looks like a kidney in a weird way, right? But not quite. This is from melanoma. Always get your skin checked, guys. Don't be messing around with that. This is mass from melanoma. Here's another mass. Some most important congenital disorders are adrenal cortical hyperplasias and causes alterations and increases in steroid synthesis, covered later by hyperadrenalism. So, with adrenal hyperplasia, anencephalic fetuses, which we'll talk about in OB, the adrenal gland consists only of provisional cortex with no fetal zone. Cytomegaloid type is causes unknown and unusual. Adrenal cortex is made up of large isophilic cells. So this is when the adrenal glands do not develop correctly. Ectopic adrenal glands consist mainly of accessory cortical material and can occur anywhere from diaphragm to the pelvis. You can have cysts. You can have cysts anywhere in the body. They can be endothelial in type, and they might have about be three of these different kinds: a pseudocyst, a lymph angiomatous or an epithelial cyst. So if you see like a black, simple, round area on adjacent to the kidney, but on the kidney near to the adrenal gland, you can potentially think that it could be adrenal cyst. Here are a couple cysts. Hemorrhage can happen. These are mostly seen in newborns after a difficult delivery. The right side is more involved in the hemorrhage process. And trauma-induced hematomas usually resolve without clinical complications. If you did see a mass, it's going to look like this. It's going to be more like complex. You're going to see different echo textures within the mass. It could be a hemorrhage. You can get abscesses, but these are very not common. More common in neonates with a traumatic delivery or septicemia. Again, with lowered immune systems, you can have a chance of having the abscess infection. So it seems like the adrenal glands can be involved in metastatic disease quite a bit. Squamous cell carcinoma of the lung, breast, GI tract, melanoma, thyroid, pancreas, kidney, lymphoma, melanoma. And you're going to see small masses 4 to 5 centimeters, but they're usually bilateral and solid, which we looked at. Cysts can be from hemorrhage, trauma, or idiopathic. You can have a hemorrhage, potential abscess or infection. You can have agenesis of the adrenal gland. So cortical pathology is divided into 3 different categories: disorders that diminish steroid output, disorders that increase steroid output, or lesions that have no functional effect. cortical tumors, adenomas, myelolipomas, or cancer. So Addison's disease is a chronic primary hypoadrenalism. And this is most common. Insufficient secretions of adrenocortical hormones result from insidious and profound atrophy of the adrenal glands. It's very uncommon. It becomes evident when 90% of functioning adrenal cortical cells have been destroyed. Two major causes are adrenal destruction or idiopathic atrophy. No one knows exactly, or if a patient has tuberculosis or autoimmune disease. So females are affected by the idiopathic trophic portion, and males are more affected by tuberculosis. Clinical symptoms depends on the degree of deficiency. Today in America, what are we directed to believe in? Sonographic depends on extent of gland destruction and tissue necrosis. So some of the symptoms of Addison disease is abdominal pain, weakness, weight loss, and darkening of skin. And it usually onsets in middle-aged females. So you don't know for sure why you would be getting this, but it sounds kind of scary. Some people say that treatment with a high salt diet can help in some people with this. So kind of nuts. But symptoms include fatigue, muscle weakness, weight loss, nausea, vomiting, loss of appetite, lightheadedness upon standing, irritability, depression, diarrhea. And some people have salty food. Hyperpigmentation of the skin may be seen, particularly when person lives in a sunny area. So yeah, that's interesting. And they can have low blood pressure. Well, kind of can go into adrenal crisis if there's quite a bit of adrenal insufficiency. Oh, it's not kind of scary. So in acute stages, there's going to be diffuse glandular enlargement, and chronic is going to be smaller. Massive destruction of the adrenals can occur at any age and in a variety of settings, causing acute adrenal insufficiency. Just makes you feel so good. You're just feel like a ticking time bomb when you're studying all this different stuff. With hyperadrenalism, the three types of corticosteroids produced by the adrenal cortex result in three distinctive but sometimes overlapping clinical manifestations: Cushing's syndrome, Conn syndrome, or adrenogenital syndrome, or congenital adrenal hyperplasia, or CAH. So Cushing syndrome is excessive glucose production from hypersecretion of cortisol from adrenal cortex. It's the most common causes of treatment of non-endocrine disorders with long courses of potent glucocorticoid drugs such as prednisone or dexamethasone. Three similar forms of Cushing disease, two ACTH dependent forms, or third is ACTH independent form, basically. So some symptoms of Cushing's disease. So this is when your body basically produces too much cortisol over time, but can result from taking too much steroid. So weight gain and fatty tissue deposits, particularly around the midsection, upper back. And between the shoulders, buffalo hump. pink or purple stretch marks of the skin, abdomen, thighs, and breasts, thinning or fragile skin that bruises easily, slow healing cuts, insect bites, infection, and acne. Signs and symptoms of women experience Cushing disease syndrome may experience thicker or more visible body or facial hair, irregular or absent menstrual periods. Other signs are severe fatigue, muscle weakness, depression, anxiety, irritability, loss of emotional control, cognitive difficulties, new or worsened high blood pressure, headache, infections, skin darkening, bone loss. So if your adrenal glands are going too much or too little, then it can cause all these serious things. A rare pseudo Cushing syndrome occurs less than 2% with alcoholism or major depression. And so we'll just keep going because I don't want to be. So I did want to talk about congenital adrenal hyperplasia or CAH. So some newborn girls with congenital adrenal hyperplasia have ambiguous external genitalia resembling those of boys, which we'll talk about more in our OB2 class. But if we have heard about like ambiguous genitalia, when you are scanning a baby, knowing the difference between a boy or girl, and when you really can't tell, like it almost looks like an in between the genitals of a girl or a boy. We call it ambiguous external genitalia. A lot of these times with this like syndrome, it's going to be a 46 double X. So it's going to be a female. But because of the increase in adrenal hormones, it's causing the genitalia to resemble more of a boy. And that's the external. The internal female genitalia is normal. So hyperfunctioning adrenal glands can appear normal or diffusely enlarged, but with normal shape. We can also have some cortical tumors, adenomas, which measure less than 3 centimeters, are found in approximately 2 to 9% of autopsies. That was just like a little mass on the adrenal gland in A. Cancer. Okay, what you need to know about this: adenocarcinomas often produce steroids and usually associated with the hyperadrenal syndrome. Cortical cancer tend to invade adrenal vein, IVC, and lymph nodes. This is a large adrenal carcinoma in an image. So I think I would just go over this and you'll be good. So adrenal cortical tumors, adenomas, what they are, sonographic appearance. Myelolipomas are going to be more hypoechoic. You remember anything with fatty tissue is going to be more echogenic, right? Cancer can be hypercoaxial or larger masses. Echo pattern varies with necrosis or hemorrhage. A pheochromocytoma is the patient typically presents with mild to marked hypertension, headache, sweating, and tachycardia. Additional signs and symptoms relate to excessive or intermittent catecholamine secretion from these tumors. 10% are malignant, 10% are bilateral, 10% are hereditary syndrome, 10% are pediatric, 10% are extra-adrenal location. Just know what it is. They could be benign or malignant, but have the similar biochemical characteristics. Usually they will remove the gland and then um, substitute with therapy, like hormone therapy. They can be occur between 25 and 50 years old. This mass in the medullary part of the adrenal gland can have different echotextures. So it can be hypercoic, homogeneous, complex, or cystic. Oh, surprise, surprise. CT is the imaging modality of this. Literally, it is, guys. It is. And the right adrenal gland, this is a pheochromocytoma, which just looks like a mass of any. There's no way that we would know that this is what kind it is. But if you do meant, what your job is to like know that there's something abnormal right there, and you're gonna measure it, you're gonna put color on it, and you're gonna explain where it is. And then it's gonna be up to the doctor to decide the follow-up and the imaging modality that will best describe this, which will be CT. A neuroblastoma, those can usually occur in the children. So those can occur in young kids, Wilms tumor. Yeah, and like we said, metastatic disease seems to adrenals glands are the fourth most common site of metastasis after lung, liver, and bone. Small metastasis characteristically are hypoechoic, round, or oval located anterior medial to the upper renal. Larger metastasis greater than 4 centimeters tend to be irregularly shaped, heterogeneous in architecture. Again, our job is to find something abnormal, right? We don't have to know exactly where it came from. It's good to know if a patient has cancer and then you see a mass there, you're like, hint, 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 this is metastatic disease, right? Because adrenal glands are very common to have metastasis. And so seeing a mass, you can kind of put that two and two together there for you. And look in B, it looks like it's invading the IVC here. All right, so I tried to make this as short and sweet as I can, but I still feel like I talk too much. But let's what we need to really think about is just knowing what the normal looks like, knowing what abnormal looks like, a couple of things that can go wrong, some of the diseases. And I think you should be good to go with adrenal glands. All right, have a nice night.